we heard from the USG not too long ago, putting all classes online. However, you guys are in a unique situation because your fourth year medical students specifically, but third years as well, aren't in traditional classes. So when that happened, I'm sure y'all got to work probably even before that. Yep. What did you come up with?
So the response to the pandemic and precautions for students is different in a medical school because our students are training in contact with patients, and every day we send over 400 students into clinics and hospitals to get clinical training. The advice from our accrediting body was that students should cease having actual contact with patients in the clinical setting effective on the 17th. So we implemented that policy, and our students were brought back from clinical contact at that time. To respond to their continuing educational needs, we felt we had to develop new coursework that would be relevant to them and also would address the need to have some still activities with the clinical setting. So we developed a new course that we're calling Pandemic Medicine. It's a course that's going to be taught across the entire state, virtually, online in part. It'll also allow our students to participate in public health service projects, to apply their knowledge in clinical settings without actually touching patients. So the goal is to give them a good base of knowledge in the area of pandemic medicine, which is obviously relevant to what they're seeing and experiencing, but also get them involved in the public health response to this pandemic by serving in support of public health experts.
What are some of the things that they're going to be e-learning?
So they will be given content related to concepts and practices of global health, health policy, public health, biomedical ethics, big data analytics, and other aspects of how one approaches a global pandemic and how one studies and affects that pandemic locally. So it's a kind of a span from global topics of pandemic understanding and management to local responses by communities.
So moving forward, obviously, we hope that we never have something like this again. However, as physicians, you guys have to plan for just about anything. So what does this course prepare these students for, say we have something similar to this in the future?
Well, we've already done a fair amount of disaster medicine content in our curriculum. We've won awards nationally for disaster medicine preparedness of the type you might think of like a hurricane, for example, right? So we're just pivoting on that, and we're taking this as a public health disaster, pandemic, and we're using the same principles but trying to modernize it for the purposes of dealing with this current public health crisis. They should be able to respond in the future, whether they're trainees or physicians, to a similar pandemic situation based on the knowledge we give them and their practical experiences in the field.
So they no longer have clinical contact, the third and fourth year students who are on clinical rotations. Does that hurt the hospital to not have them there?
Students are part of the care team, and the Association of American Medical Colleges considers them to be an important part of the care team while they learn. We've been advised to temporarily take them off the care teams that they've been part of, and we did so. But yes, hospitals rely on learners, whether they're students or residents, to help to understand patient care issues, to deliver patient care, and to be part of that model of care that we were used to doing in academic health centers. So yes, there will be an impact of not having learners in that setting, but we hope to redeploy them into public health phone banks, into screening operations, and into tracking cases of patients that may have contacted the COVID virus with the proper training. So they'll become a highly trained workforce of their own, and with over 400 of them available to us now that we didn't have a week ago, we're going to deploy them by the 30th of March and get them out there in those settings with the right knowledge to work effectively.
What has the response been from these students?
They're very excited. They want to serve. They want to be part of the response to COVID-19. They have a great deal of a service mentality already. Our students are very service-oriented. As Georgia's public medical school, we try to imbue that value system in them, that they want to be part of any kind of public health response that they can be. So I think they're ready, willing, and able to serve, and they'll be well trained to do so, and we look forward to their service. And David and I were interacting with our student leaders last night, and they're all very, very thoughtful people who kind of represent the best value system within our medical class, and they're just the epitome of the desire to do something effective, to get into play, but to do it with the right boundaries so that they don't overstep what they really know or get into a situation where they end up causing harm, right? We always try to walk that balance between you you practice to the best of your ability, but you don't cause harm,
Right.
and you try to walk it back and forth.
What about that group?
So for the students who are on a variety of rotations during the year, some of the students have not yet completed their requirements for graduation. So what we want to do is be mindful of the fact that everything has changed and they still need to adapt to this situation and acquire the knowledge. So for the 60 or so students that are in that situation now, we're finding alternatives for them to do clinical work, to get credit for the clinical work. It may not be hands-on patient contact, but it will be the equivalent, and our curriculum will allow for them to graduate on time.
So today would be, I guess still is, match day, and that's typically a really exciting time for fourth year medical students, and they're not experiencing that. Disappointment for sure, but I'm sure there's also a level of, we gotta do what we gotta do. What's the vibe around campus about that?
Well, they're disappointed that it's not an in-person match day. It was going to be down at the Miller Theater. But the students, and we didn't even know this was all going on, in the last week designed a virtual match day. So that's been put together. There's a website. We actually recorded videos for it yesterday. The students are going to basically record some videos, upload it to a website. So a lot's going to happen. It's going to be different. It's something they'll never forget for the rest of their lives.
Yeah, and something that's never been done before either.
Well, not here. I'm sure other medical schools are probably going to come up with creative ways, but our match day is unusual. A lot of medical schools, they call the students up, they give them an envelope, they sit down. It's kind of a boring match day. Our match day, people dress up in costumes and get together. We're not going to have that, so we're going to miss that. But I think it'll be something that we'll always remember.
Do you have the stats for where people match and stuff?
About I think 99% of our students have matched to a residency, and I think about 60% of those are in primary care residencies, and that primary care is defined by the Georgia Board for Healthcare Workforce. So that includes pediatrics, internal medicine, OBGYN, general surgery, psychiatry. I think about 30% matched in the state of Georgia, which is about how it is. One of the things is our medical students are probably the best in the nation. I'm a little biased, but I really think they are. And they can go anywhere. And so they can match at great programs. And so sometimes it's hard for us to keep them here at the Medical College of Georgia in our residency programs. They're so good they can go anywhere. So in a way, we're a victim of our own success. We'd like to keep more. But we're working. That's why the 3+ program is so important, that Dr. Miller and his team, great redesign of the curriculum, will aim to keep those students in Georgia residencies and then practicing in Georgia, and then save a year of medical school, and hopefully, eventually pay their tuition if they stay in state. So, more to come on that.
Yeah. Well, and you mentioned residency, and something that I didn't ask Dr. Miller about. How has this pandemic affected our residents here at the medical college?
Well, it's a very good question, and it's evolving. One of the things we want to do if our residents and any of our healthcare workers, become infected, that's a real problem, because then we have to potentially isolate their contacts. So we've had to restrict. Some residents now are interviewing for fellowships, so that's one problem there. Is we really have got to discourage anybody from traveling anywhere. Because most of the infections that have come into this area have come from people traveling and bringing it back.
Yeah.
So some of our residents are involved in providing telehealth consults for COVID screening. We always have to balance and be careful with that, because the residents have an 80-hour work week rule, and so we got to make sure we don't violate that. So when they work, we have to be very careful they do it under ACGME guidelines.
Yeah.
Because that's always a real concern. We have to make sure that residents also have an educational experience, as well as delivering care.
Right. I always say they're hybrids. They're part doctor, part student.
That's right.
You mentioned that. So Dr. Miller already addressed this some, but we have resources at an academic medical center that other health centers don't have access to, the students, the residents. How crucial is that, more now than ever, to kind of reallocate, like you said, residents going to do those, telehealth things? How does that help you guys provide care to people in a pandemic situation?
Well, yeah, and we're not sure where this is going to go. If you look at northern Italy, a lot of medical students are now becoming frontline caretakers, right? And, I have friends in Denmark, And Denmark, is a little bit ahead of us in the epidemic too. Now it's not as bad there as it is in Italy, but there the medical students are out, swabbing patients at drive-through screenings and much more involved in medical care. So they've had to put them into medical care. Now we're not there yet, and the first priority, as you know, is the safety of our students. That's why we ceased rotations. And anything we do with them in the pandemic medicine elective will be virtual and remote.
Yeah.
And so we're going to focus on keeping them safe. But yes, there's hospitals now. The JAMA network I watched a video last night in California. The Kaiser system has actually the biggest shortage is critical care doctors. If critical care doctors get sick, and you have severely ill patients coming in that need ventilators and need critical care doctors, they're taking their hospitalists there and making them work as interns under the direction of their critical care doctors.
Mm-hmm.
Dr. Mill and I were just discussing it could be that we have to go back to the front line. So, anything can happen. So
Right.
what the real concern would be if our physicians did get infected and were pulled out of providing medical care.
Yeah.
And being a level 4, really a medical center or a level 1 trauma center or a comprehensive stroke center, and we're going to get probably the sickest patients. And so we just have a finite number of physicians. And as you know, there's we have a lack and a shortage of protective, equipment to protect ourselves, and recycling that all comes into play. That's why we stopped elective surgery here, to kind of preserve your workforce and preserve your materials, because there's a shortage of materials. It so happens that a lot of these supplies were actually made in northern Italy. Or China.
Right.
So where the epidemic is where a lot of these medical supplies come from.
Right.
So that's led to a shortage. So there's a big shortage in protective equipment. And there's a potential shortage of physicians. Now we haven't hit that here, but that's a real possibility. That's why it's so important to do mitigation. As you heard Dr. Fauci say in the news every night, social distancing, mitigation is the most important thing to do. The encouraging thing, in China at least, not so much in Italy, in China there's no new cases from Chinese, only people from coming in. Now that hasn't happened in Italy yet. So that's why we have to plan for the worst and hope for the best.
My last question is, Dr. Keel in his town hall yesterday had a list of people to thank from across the academic side and across the health services side. How has that collaborative effort gone since the start of this in terms of all facets of this institution working together to serve this population, the state at large, and potentially moving forward the country?
Yeah, well, we're an integrated academic health system, and we're the only public academic health system in Georgia. Okay. And I think it's worked really good. I think you interviewed Dr. Coley last night. So Dr. Coley is a faculty member of the Medical College of Georgia and runs the GEM lab in the Department of Pathology. But we're all integrated into the hospital, right? The hospital and the medical school and the physicians who work here, we're all integrated. So we're all in this together. Yeah. So Dr. Coley is on our faculty, but providing this service to the hospital and our employees and to the whole CSRA. Yeah. In the same, we have medical students now who we've withdrawn, but we're trying to look for ways that they can volunteer. Yeah. Not just here, but as Dr. Miller said, all throughout the state of Georgia. Because don't forget, Georgia is our campus. Yeah. We have a well-developed regional campus system. So we're very concerned about Augusta, but we're concerned about our students all throughout Georgia at all of our regional campuses, in Albany, in Rome, in Athens, our partnership campus, in Savannah and Brunswick. So yes, we're all working together on this. The residents are, MCG employees. The residents are ours, but they work in the hospital, and right. So that's a tight, that's tightly intertwined. You really can't separate the health system from the medical school and its faculty and its students and residents.
Perfect. Did I get everything?
Yeah, if you want to talk a little bit more about the statewide, because we're already statewide. I don't know if you want to kind of delve into that.
Especially because Albany has been hit real hard.
Yeah.
Then I'll just ask pretty open-ended question. What are we doing regionally? And that's a good point, Jennifer, because we've gotten a lot of questions from people in rural areas. We keep hearing about what AUMC and MCG are doing, but what about people who are in Washington, Wilkes, and those areas?
Right. Yeah, so we have campuses and students go all throughout Georgia. Now, we pulled them out from the sites, but our regional campuses also work closely with the Georgia Department of Public Health. So there's 18 public health districts in the state of Georgia. 7 of those districts now, the director is a Medical College of Georgia graduate. So beyond working with the health systems, we're also going to work in this pandemic medicine elective with the public health districts. And the idea is that all these 18 districts will have MCG medical students involved, volunteering as part of this elective. So they're going to get online training, for 2 hours a day at least. But then the rest of the day, they can do a lot of virtual volunteering, phone banks, epidemiological tracking. So there will be a student, if not in every 159 counties of Georgia, there will be a students involved with every public health district in the coming months. So that's exciting. So really, Georgia's our whole scope.
Right.
And the rural patients, we really do serve the other Georgia. We're the outside the perimeter campus, and we also serve Atlanta.
Yeah.
But rural Georgia, tends to be forgotten. And throughout the country, people in rural areas have higher mortality. That's been clearly shown. Tend to be lower income. So those are the people at particular risk, and they don't have the resources. And even internet access is poor. Not all of them are savvy with smartphones.
Right.
And a lot of them don't have broadband access in rural Georgia, and this is something that's been going on for years that we're trying to address. So how do they keep in touch? Yeah. Who's and as their doctor's office closes, what do they do? Well, we always have the public health departments, all right? And so our regional campuses work really well with them. Last week we had a conference call where we had 2 of the public health district directors, MCG graduates, on our call with our regional campuses, trying to figure out how we work together. And really, kind of out of those discussions, Dr. Miller and his team came up with this pandemic medicine elective to really get our students out into these areas. And we actually heard about their concerns. And what can they do? Well, for them, calling an 800 number is really probably the best public health thing. Right. And doing that kind of screening. One of the things we lack now is the ability so far to test patients, to get the blood test. That's why Dr. Coley's work is so critical. That's really kind of held us up. Korea developed testing pretty quickly. Yeah. And that's one difference between them and the United States. We had some stumbles here, but I think you're going to start seeing testing become more available. But the biggest problem are the supplies and the reagents and the plastic for the testing. Who would have ever thought that we'd have so many problems with our supply chain?